Hey everybody, welcome back. David here with Med School Bootcamp. So we are going to finish this chapter with talking about urinary casts. Remember, as we've said in the previous videos, there is actually a lot of information, a lot of pathologic information we can get from a patient just by looking at their urine sample. And the final thing we're going to talk about is urinary casts, as these are findings that can clue us into not only what the patient has, but also where is it coming from, which portion of the urinary system. It's important to know that things like bladder cancer or kidney stones are certainly pathologies in the urinary system, but these do not present with cast. So while bladder cancer and kidney stones might present with hematuria, they do not present with urinary cast. This is important, right? If we're working up a patient and we don't see any urinary casts on inspection, this helps to narrow our differential diagnosis. The next important thing I want to talk about here before we start talking about urinary casts specifically is that there are a couple conditions such as acute cystitis that will present with pyuria. However, it would also not present with urinary cast. So we can then add that to our list here at the top. Acute cystitis is another one that will not present with urinary cast. So now let's talk about the pathologies that will present with urinary cast. And the first one I want to talk about is that of the fatty cast. Fatty cast is most commonly going to be seen in nephrotic syndromes. And again, we have a whole video coming up talking about all the differences between nephrotic and nephritic syndromes. But the key here is to remember that a nephrotic syndrome is going to present with a high amount of protein, greater than 3.5 grams per day. And so a really good way to remember this is to remember that in a nephrotic with a big red O, we will see higher levels of protein also with a big red O. So this kind of mental visualization of the giant red O in nephrotic and protein can help you remember that, oh yeah, nephrotic syndrome is associated with high levels of protein in the urine, and that can present with a fatty cast. These casts are also occasionally called oval fat bodies. However, I would say fatty cast is the more commonly used term. Key point I want you to remember here is that these are also associated with something called a Maltese cross. And essentially what that means is that when you look at these casts on microscope, you will see something that kind of has a Maltese cross appearance. So whereas a typical Maltese cross might look something like this, if they were to show you something that looked approximately about that shape, maybe with a little bit more smudging that looks something like this, that is approximately in the shape of a Maltese cross, and that's indicative of a fatty cast. Next, we're going to talk about granular casts, and the main one that you need to know here is this buzzword, which is muddy brown. This is almost pathognomonic for an acute tubular necrosis at this level. And acute tubular necrosis is essentially a process where cells that typically line the tubules, I'm drawing here in brown, become necrotic and slough off into the tubules. This results in them kind of sticking together and creating a bit of an obstruction in the tubule as well, which ultimately would do what to GFR? That's right, it would decrease GFR because we now have an obstruction. These cells can create a plug, which can be seen in the urine as a fatty cast. So you can imagine, right, if this kind of obstruction right here makes it all the way through the urinary system and it becomes a part of a urinary sample that we're looking at on a microscope, we can see these collections of dead cells, these muddy brown casts, which is indicative of acute tubular necrosis. Next, we have our hyaline casts. Key point here is that these are relatively nonspecific. So the presentation of these potentially indicates something's going on, but it doesn't tell us specifically what's going on, right? I said to associate our muddy brown cast with acute tubular necrosis because that's the most common one that they would test you on. However, a hyaline cast doesn't really give us a clear specific pathology for the patient. And the reason is because this is associated with several different things. This can be seen due to dehydration in a patient, which can be a result of a variety of different things, right? A patient who's on diuretic therapy could become dehydrated and then have a hyaline cast. A patient who overexerts themselves, someone who's come in from running a marathon and is very dehydrated, could also present with these hyaline casts. So it doesn't necessarily tell us what specifically the patient has. An associated word that I want you to be familiar with, as sometimes it is used in test questions, is this Tam-Horsfall mucoprotein. This is also called uromodulin. Uromodulin is the most abundant protein excreted in the urine, and it's thought to play a role in UTI prevention via tubular cell secretion. This is not something I've seen commonly tested, but again, I just want you to be familiar with this word of Tam-Horsfall protein or uromodulin in case it shows up in a question stem. That way you kind of have an idea of what they're talking about. They're probably talking about the non-specific hyaline cast. Next, we'll talk about the red blood cell cast. So this is going to be a little bit more straightforward. Patients that have glomerulonephritis or hypertensive emergencies are going to present with these types of casts. So glomerulonephritis is just saying that there's a disease process that causes inflammation in the kidney, and we're going to talk much more about these when we start to talk about our nephritic and nephrotic syndromes in the upcoming chapters. And recall, a hypertensive emergency involves a patient who has severely elevated blood pressure with additional end organ damage. One of those organs that can be damaged is the kidney, and thus this is an associated finding for patients who have hypertensive emergency. Next, we have our white blood cell cast, which can be due to a variety of different things, including acute pyelonephritis, transplant rejection, or tubulointerstitial nephritis. Much more about these types of conditions in the upcoming pathology section, but the main one I want you to remember from this group is acute pyelonephritis. Again, we have a whole video on this later in our pathology section, but in short, this is an infection where neutrophils or white blood cells have to actually go to the renal cortex in the renal interstitium to fight an infection. So because we have an infection high up in the kidneys and we get an abundance of white blood cells in the area, it would make sense then that we could ultimately see white blood cell casts in our urine sample. And finally, the last one we're going to talk about in this video are waxy casts. And waxy casts can be indicative of end-stage renal disease or chronic kidney disease. Similar to our hyaline cast, this is a bit of a non-specific finding. It's thought that it might be due to renal stasis, but because it's a fairly non-specific finding, it's less likely that they would test you on this concept directly. It's more likely that this would be presented in a question stem where it might be additional information, but not necessarily the only information you would need to get the question correct. I think it's important to go over these terms because I want you to be familiar. If you see them in a question stem, you can acknowledge whether or not it's a piece of information that you definitely need to answer the question, or maybe you don't need as much to answer that particular question. All right, so that's all I have on this chapter for pathology diagnostics. Really going over some of the basics here, some of the really high yield stuff that question writers love to ask you all about. So I think if you've gone through the videos in this chapter, you'll have a pretty good foundation, a pretty good understanding of some of the urinary stuff that we're going to continue to build on throughout our pathology chapter. And with that said, I will see you all in the next chapter.